My name is Dr. Raja Mudad. I'm a thoracic oncologist at the Sylvester Cancer Center in Miami, Florida. So today we discussed several results of trials that were presented this year at ASCO. Some of them may be practice-changing. The first one is the role of next-generation inhibitors for ALK, which is one of the mutations we see in lung cancer, and the activity of this drug in patients who have never been treated before versus patients who have received another drug in first line. Another important point we discussed today is what do you do in patients who have lung cancer who have progressed on immunotherapy? Do you actually keep them on immunotherapy? Is there a role for maintaining them despite radiologic progression? Or do you have to switch them to a different type of therapy? And that was actually very intriguing in terms of suggesting that patients may benefit from continuation of immunotherapy despite radiologic progression. We also discussed today whether there is a role for tyrosine kinase inhibitors in adjuvant setting in lung cancer. So patients who have had surgery for lung cancer, if their tumor harbors a mutation, do they benefit from being on a targeted drug like a tyrosine kinase inhibitor or not? We also discussed today the role of dual immunotherapy, meaning two immunotherapy drugs in the small cell lung cancer. So let's take these one point at a time. Alectinib is the first one we'll discuss, and this is a next generation tyrosine kinase inhibitor for ALK positive tumors. Alectinib is a drug that inhibits the protein that is produced as a result from this mutation in lung cancer. Those patients account for about 5% of lung cancer patients. So it's not an extremely common patient population, but they actually have a very peculiar characteristics. The most important one is that these patients tend to have a significant incidence of brain metastases, both on presentation and during treatment. But 30% of patients with ALK positive disease have brain metastases on presentation. During treatment with a first generation inhibitor, about 60% of patients will develop brain metastases. So this trial, looking at whether we use a drug that is more active than the one we currently have, has a benefit using it first line. So patients were randomized to either receiving crizotinib, which is the approved first line treatment, versus alectinib, which is the newer drug. Now, alectinib is approved in the US for later lines of therapy, but in this trial it was used in patients who have never been treated. What this trial showed is that there was a significant improvement in the progression-free survival of patients who have received alectinib versus crizotinib. Another very important point is this drug has a significant activity in the brain. So patients who already had brain metastases and were randomized to receive alectinib did incredibly well compared to crizotinib because there was a significant response in the brain just by taking the medication even without radiation versus if you're on crizotinib, there isn't much CNS penetration. And also the progression in the brain in those who have brain metastases and were treated, there is less progression if you are on alectinib versus crizotinib. So the importance of this trial is it will lead to the approval of alectinib in first-line treatment of patients with ALK-positive disease. Let's move on to the role of gefitinib in the adjuvant setting. So the standard of care for patients with lung cancer who have had surgery, meaning patients with stages 1, 2, or 3, in the US is to administer to a specific population if they have lymph node involvement, essentially stages 2 and 3, 4 cycles of platinum-based chemotherapy. Sometimes if they have also N2 disease, we add radiation in a sequential fashion. But then after that, we typically just finish treatment, we watch these patients, and we continue to monitor. If those patients have a mutation in their tumor, at this point, there is no standard recommendation to do anything specific for that tumor. We currently only treat patients who have this mutation if they have stage 4 disease with a specific inhibitor. In this trial that was out of China, took patients who have had surgery for lung cancer who specifically had an EGFR mutation. And what they did is after surgery, they randomized these patients to either chemotherapy, the standard of care, 4 cycles of platinum-based chemotherapy, or gefitinib, which is an oral tyrosine kinase inhibitor, for 2 years. Important point to make here is in the US, we're doing a very similar trial, and this is still not mature yet or even finished accruing, but we're taking a different approach. In the US, instead of randomizing patients to chemotherapy versus the targeted inhibitor, we are allowing patients to take chemotherapy and standard of care and finish everything and then randomize to observation versus a TKI. So that will be answering a different question. But back to this trial was positive in terms of improving disease-free survival in patients who have been resected and who have an EGFR mutation if they were placed on a TKI versus if they were placed on chemotherapy. At this point, I would say this is not practice changing in the US because we are awaiting the results of our own trial that is using this TKI after chemotherapy. Third thing we want to talk about is what do you do with patients who are on immunotherapy, who may have some progression on x-rays, but they're feeling very well. They have no tumor-related symptoms, they have no side effects from the immunotherapy. Can you maintain them or keep them on immunotherapy despite progression? So it's a very interesting point because it really brings up the issue of how do you decide that somebody is progressing? Traditionally, is you do scans, you see tumor progression, you stop the treatment, you move to a next treatment. That has really been true in the era of chemotherapy. But in the era of immunotherapy, we are seeing that this may not always be true. Meaning you may be on immunotherapy, your scans may show some progression, but the patient's still feeling great, have no side effects, and all their tumor-related symptoms continue to abate or get better. So in this particular trial, they looked at a group of patients who were on immunotherapy, but who were not taken off despite radiologic progression. And what this trial found is that those patients who stayed on immunotherapy, feeling well, again, not having any symptoms, did actually very well, and their median duration of staying on immunotherapy was an additional year with no change in therapy. So this trial really, in some way, confirms what we currently tend to do in non-small cell lung cancer. That is, despite radiologic progression, if somebody is feeling well, we tend to keep them on immunotherapy. The fourth trial I presented was, is there a role for dual immunotherapy? Meaning, we now use one drug in immunotherapy treatment in general. Can you combine two of them? Now, the two that are most commonly combined are not targeting the same part of the immune system. So we use either a PD-1 or PD-L1 inhibitor as the backbone. But now if we combine it, we're combining it with something called CTLA-4 inhibitor. And in this trial, they used a combination of nivolumab and ipilimumab. They're both immune inhibitors, but they target different parts. And this was tested in small cell lung cancer. So patients with small cell lung cancer, unfortunately, do not have a lot of options. After failure of first-line chemo and second-line chemo, there is really no standard of care at this point. So the question was, can you give them double immunotherapy? And in this trial, where it was looked at using the combination of nivolumab plus ipilimumab, and there was certainly improvement if you used both drugs. That improvement was seen in the response rate. Response rate was almost double using dual immunotherapy versus one immunotherapy. Duration of response also was better with dual versus single immunotherapy. There is no survival benefit at this point. And again, these are patients who have already exhausted two previous lines of therapy. So currently, there are randomized trials specifically looking at this combination versus single agent.